Gentlemen, welcome to today's Supportive Care Coalition webinar. Today's presentation is titled Palliative Care Program Financial Stability in the Post-COVID Landscape, presented by Dr. Kevin Murphy. Before we get started, I'd like to mention that today's session is being recorded and you are currently in a listen-only mode. You will be receiving an email tomorrow with access to the recording to listen to on demand. We will be having a question and answer session at the end of the presentation, and you may type in your questions to our speaker at any time using the questions panel on the right side of your screen. If you experience any technical difficulties during today's webinar, you can click the Help tab at the top of your control panel or ask me a question directly in the questions panel. Now, without further delay, it is my pleasure to introduce your moderator for today, Denise Hess, the Executive Director of the Supportive Care Coalition.
Thank you, Brianne, and welcome everyone to today's Supportive Care Coalition webinar. For those of you learning about the Supportive Care Coalition for the first time, the Coalition is a partnership of Catholic healthcare ministries from across the United States dedicated to advancing excellence in palliative care through ongoing advocacy efforts at the local and national levels, through interprofessional education, resources in healthcare ethics, and the integration of spirituality in palliative care practice. Coalition members have complimentary access to monthly webinars, numerous resources on our website, and a community of like-minded learners from all disciplines represented in palliative care. Today, we are delighted to welcome Dr. Kevin Murphy. Dr. Murphy is the system lead for palliative care with Providence St. Joseph Health, where he directs the enterprise efforts to expand and optimize specialty and primary palliative care across 7 states and 51 acute care hospitals. He has served in clinical leadership roles across the United States, including Regional Director of Palliative Care for Providence St. Joseph Health in Southwest Washington. He has expertise in palliative care program development, clinical integration, healthcare delivery, management, behavioral health, and emergency services. And so without further delay, I will turn it over to you, Dr. Murphy. Welcome, and thank you so much for joining us today.
Thanks, Denise. Thanks, Bree. Thanks for all your help. And welcome, everyone. I have to admit that when Denise and I first talked about doing this presentation and we came up with the title of Palliative Care Financial Stability in the Post-COVID Landscape, I thought it seemed to have felt a little lofty and opportunistic, but as I was thinking about it, and as I was developing this, I realized that I don't know about you, but I don't feel like we're in a post-COVID era. I feel like I'm going to just strike through that, and we're going to talk about palliative care right now, and how do we maintain, sustain, and even for those of you who are looking to do this, build a program based on all of the turmoil and tumult that is occurring in the healthcare arena. But before we jump into that, I want to just take a moment. We're going to center ourselves and we're going to be at peace with the fact that the changes in the world that we live in has been made a better place by a woman of substance and a woman whom I wish I had had even 1/100th the impact on the world. Here's a couple of quotes for you. And I'm going to say one more thing before just calling for a moment of silence. I was watching the news this weekend in remembrance, and one of my favorite news anchors commented that she was 87 years old, barely 5 feet tall, but a giant by any measure. 27 years as a justice of the Supreme Court, and innumerable impact and uncountable proposals and laws that have been passed and impacted by her. So I'm just going to ask for a quick, let's go for 15 seconds. That'll be. Okay, and thank you, Justice RBG. If you haven't seen them, there is a phenomenal documentary done by her nephew and obviously the blockbuster film on the basis of sex that came out last year is well worth your time. And I'll end with fight for the things that you can care about, but do in a way that will lead others to join you. Thank you, Ruth Bader Ginsburg. May her memory be a revolution. Okay, so you guys have all seen this. I'm not going to belabor the point. What we're going to talk about is going to be a lot of content. We're going to try to get you this information. I've got some resources at the end for you, and I've got some information for you. I'm going to get through some of this details and some of the didactic component so we can actually move into a discussion, because a lot of this is going to be better digested in small bites. And so who's this guy standing in front of me talking about palliative care? Denise mentioned that we are a 7-state, 51, now 53 hospital system. We are a West Coast institution. And I actually work for Ira Byock. He's this little known author that you may or may not heard of. We are the Institute for Human Caring, and that is a team of healthcare leaders, clinicians, and change agents across all of our states and all of our ministries who improve and strive to improve healthcare, especially to the most vulnerable. The Institute, I'll read their mission statement. The Institute for Human Caring, we believe that whole person care is essential to helping patients, families, and caregivers experience the best care possible, and this requires attending to the body, mind, and spirit. The foundation of healthcare change and innovation in the modern era is built upon this quadruple aim that we've heard about for so many years, triple aim, now quadruple aim. And one of the things that I want to point out is that in order to do the triple aim, we really need to focus on our caregivers, on our clinicians, especially in this time of COVID, where we were running out of PPE, where our caregivers are becoming ill, where one of our brethren, and I'll just call out a 28-year-old emergency room physician who died this past week in Houston, serving COVID patients from COVID-19. But improving our clinicians' well-being is going to serve us in taking care of the first three. And I don't want to give anybody PTSD reminiscent of biochemistry and this feedback loop, but they are all interconnected. So with that, we're living in COVID. We have changes that are impacting everything we do, from grocery shopping to schools to work. This platform is televideo. This isn't new. We did this the same way the last time I did this a couple years ago, maybe it was a year ago. But healthcare is changing, and it exploded in March into televideo and telehealth options. Now, we've been doing televideo platforms for several years, and I know a lot of you have as well. But what we noticed and what we've been struggling with is that there were some specific delivery modalities that were the most crucial to a change during COVID-19. Those being hospitalized patients in isolation, especially as we tried to maintain and save personal protective equipment. There's this phenomenon called interprofessional collaboration, which we'll talk about more, and then of course family meetings, kind of the bread and butter of what we do. So when we took a look at our teams, we realized that we had some challenges and we had some needs. And so the Institute for Human Caring pulled together a COVID-19 response team, and we pulled together the best known practices on televideo. We drafted this end of life visitation recommendation for our 51 hospital system, which has been implemented to both ensure high quality and high impactful visitation and support of family and patients during the end of life care, but also ensuring safety of our caregivers. In addition to that, we created some teleresources, but what I want to point to you is over on the right is that of our 53 hospitals, we had 18 hospitals that were using tele-PC for inpatients in isolation. We had 14 who were using tele-PC for IPC, interprofessional collaboration, and we had 25 of those who had converted to tele-PC using them for family meetings. And we'll talk more about that and what that means. But in order to support our teams, we pulled together daily COVID responses, weekly leadership meetings where we could share best practices, where we could share resources. And we also just did a round robin with all of our program directors and medical director leaders, mostly for support, kind of a therapeutic debrief, but also for ensuring that everybody knew what was going on, when it was going on, and things that had been tried, so we were not reinventing wheels in 52 different ministries. What we learned with telehealth is that CMS was changing everything on a daily basis. It was hard to keep track. There were coding and billing changes, and we developed a launch pro forma. So how do you fund it? How do you finance it? And this is a suggested way of doing it. And those were all put forward. Now I'm going to give two shameless plugs here. The first one is to my colleague within the Institute for Human Caring who started this website called the Coronavirus Chronicles. Thank you, Mike Drummond. This is a beautiful human touch, caregiver directed, caregiver story compilation that is on our website, and I'll share with you here on the next page what that website is. And what it did was that it asked caregivers to share what they were experiencing, how they were experiencing it, and just let them have a free space and a place, a platform to have a conversation with themselves or with everybody else about what they were experiencing. Secondly, one of the things that we realized is that when everybody put masks on, patients, physicians, nurses, even the environmental services all wearing masks, that we had to have a connection and face on those. And so all of our caregivers started wearing pictures with their names so that even under their mask, you could see who they were. And we turned it around and gave all of our intensive care patients this platform, which we refer to as the Get to Know Me poster, which belongs to them. So it's not HIPAA concerned, but it allows for the family and for the patients to share in real visual space who I am, and this is who you're treating. I am not the person in bed 8 with coronavirus. I am me, and this is who I am, and these are the things that are important to me. And this was very impactful for both the families, the caregivers, and the patients. The families we heard say things like, wow, I really felt like my parent, even though I wasn't there at their side, felt love. But we have to keep this up. We have to maintain the flow and the progress that we're making. And so in order to do that, we pulled together a team that tracked these CMS changes. So in early March, CMS said we will pay for televisits. That was new. For years and years, we've been fighting with CMS to do this. And what we've heard is there's not enough data, there's not enough proof showing that the televideo or the teleplatform is beneficial. Well, guess what? We have a ton of that now. So we also received confirmation that new patient requirement was going to be waived. And so for those of you that have done televisits, you cannot establish care via teleplatform. But now with COVID-19, you're able to. So you were able to do a new visit or an initial visit via televideo platform, and we'll talk more about that. And you can also conduct your visit from anywhere. Historically, the provider had to be in a specific location and the patient had to be in a specific location. Now we can do televideo from home to home, from clinic to home, from clinic to hospital, et cetera, et cetera. And so that opened up opportunity that was immeasurable. The last one here, I will admit I don't like, but I completely agree with. And so specifically HIPAA compliance is going to be waived. So platforms like FaceTime and Skype are allowed. They are not HIPAA compliant. They are not safe to be used for health protected information, but during the COVID-19 waiver, there will not be any penalties for using those platforms. And so our teams and the ones that were struggling with other platforms asked for the option, and we have moved forward with a yes as a last resort, but preferably we would use a HIPAA compliant platform, for example, Zoom. CMS also allowed for us to be paid for these services. Medicare said that if you were doing a telephone visit for an outpatient encounter, that they would pay that just as if you were sitting face-to-face in the office. So instead of a phone visit, instead of a phone visit 99441, you would bill that as a in-person clinic visit established 99212. Significant difference in reimbursement, but also significant difference in documentation and all of the rules about when you can bill for phone visits. Also, CMS has waived the video requirement for selected services, so you can use audio only for advanced care planning. Look at that. So beneficiaries can use audio only telephone visits to receive advanced care planning, which of course is not allowed under non-COVID times. So if any of you have ever seen a presentation by me, you know that I like to talk about the billing and coding because it is the easiest way for you to impact your bottom line. If you are not billing it correctly, you're leaving money on the table. So this list right here includes our acute consult platform, basically, which is your initial visits and your subsequent visits. I've included also down here your prolonged services with the patient, your prolonged services without the patient, and lastly, your advanced care planning. This is the primary quiver that is the palliative care billing and coding on a consult team. The reason I'm showing you this is I'm not going to spend a lot of time on this, but you can see just for reference point that there's the level of the visit, it has your CPT code, there's a short description, there is a threshold time which you have to meet in order to bill based on time. There's the CMS allowable. Now caveat, this is my MAC, this is not the national number, so it might vary by a couple dollars depending on where you are. There is a work RVU and a total RVU. That is significant for only calculating your productivity time. I would not recommend that you base finances or your payments on this worker total RVU, but we can talk about that. The reason I want to compare this to telehealth is that these are almost cut and copied from the inpatient consult. So these are not G codes of old, but they start with a G0425 through G0408, which are the inpatient teleconsult. And they are the same times. They are slightly different, but within a % of CMS allowable. And the work RVUs and the total RVUs are exactly the same. You can see right below that there is a prolonged service associated with a televideo visit. There is also telepharmacy management that is a coded and allowable visit. You can see that there is no RVUs associated with that because there aren't any published RVUs yet, but look at that, CMS has an allowable dollar amount, which means that they will reimburse for it under certain circumstances. Not all payers will, and that will depend on where you are in the country. Lastly, down there on the bottom, televideo, telephone, no matter what you're doing right now, advanced care planning is a component of what you are doing, and you need to add that into your billing and coding. If you're not doing it, obviously you're not going to add it, but when you're spending a significant amount of time doing this, greater than 16 minutes, you need to add that or you're not getting credit for what you're doing. All right, lastly, we talked about these telephone things. So I can call my patient and I can talk to them and I can bill it like a visit. So the guidance that we have been given and we are giving is that if you are changing the modality through which you are providing care because of COVID-19, whether that's PPE, maintenance, saving, or just the patient can't come into the hospital, patient can't come into the clinic, so we are doing it telephone or telephonic, you would bill that visit just as if you were doing it normally. I'm pausing on purpose. Now, if you have always done telephone visits, or if you've always done televideo visits and it's not changing, then you would bill it like you had before using those previous codes. And down here on the bottom, you can see that we have the telephone visits, and you notice there's a color change there. The reason there's a color change there is because those are the same cut and pasted CMS allowable work RVUs and total RVUs from the outpatient clinic visits, the 99, 212, 213, and 214 respectively. We'll talk about those telephone visits in a minute, but I mentioned this interprofessional collaboration. We have historically referred to interprofessional collaboration as curbsides. We all know it. When you're on the oncology unit, the oncologist walks by you and says, hey, grabs you by the coat sleeve and says, I want to talk to you about this patient. You spend 15 minutes talking about a patient and you give some recommendations, you have some comments, you have some theories, you have some thoughts, you share those with them verbally. Well, if those curbsides are done via an EMR and or telephonic and or email, those are a billable service now. And this isn't because of COVID-19. This actually happened at the beginning of the year before we ever knew about COVID-19. However, they are 5 to 10 minutes, 11 to 20 minutes, 21 to 30 minutes, and greater than 31 minutes for level 1 through 4. And that is for us, the provider of the consult team. So you have to have a request just like you would normally, and you have to have a verbal and a written response. Your total time includes the time on the phone with the requesting physician, the time in documentation, and the time in review of records. So the likelihood of us doing a 5-minute interprofessional collaboration is pretty low, but it does exist. And then those last two, the 99451, is if you are not talking to the person, you receive an email or only a request to the EMR, and you write a quick note in the EMR. There is no telephone visit. Now, none of these codes actually involve a patient visit. They cannot be billed if you have had a visit with that patient in the last week, or if this interprofessional collaboration then results in you performing a consult. This is then going to be just calculated as your prep time. That last visit, that 99452, is the interprofessional collaboration time spent by the requesting physician if they are not in the hospital. So for example, I go home, I'm doing some notes, I request palliative care consult from my home EMR because I have access through Citrix, and I can bill for that time based on that. It only includes time that is not directly in the same facility as the patient. So that's going to be rare, but it's also not going to be us because we won't be the ones requesting our own consults. So let's talk about these phone consults on the bottom. Physician versus non-physician. For our purposes, physician refers to provider. So for palliative care specialty services, physician can be the medical doctor, the MD, DO, APRN, or PA, who is providing the provider level service for physician. This non-physician down below is not a new code, but is now allowable given the ramifications of COVID. However, you can see that there's no dollar amount under the CMS allowable because CMS does not reimburse for this. Historically, this has been a non-physician, so nurse, social worker, therapist, etc., who receives a call from outside of the hospital that is not in follow-up to a visit within the last 7 days. Now with COVID, this can be either direction, meaning that we can call the patient about an issue, or they can call us, and it is billable, and it should be billed for services that are provided, but right now it is not reimbursable. I highly recommend that these are calculated because it does count as your productivity, but right now it is not reimbursable. It doesn't change the amount of work that you're doing. It just gives you a checkbox for proving that you did it. So great. We talk about this billing and coding, and we can add that to our resources, and we have the provider doing that, but we don't bill enough to pay for ourselves. And so we're at this crossroads, and I like this video, this visual, because we're at this crossroads of trying to move from a value or from a widget counting environment into a value-based purchasing environment where we are actually getting paid for the quality of care that we are providing, whether it is preventing a hospitalization, whether it is aligning care with the patient's wishes, which is preventing a rehospitalization, what have you. But no matter what we do, most of us and most of you are working within this fee-for-service model that we talk about, that we've historically known, which is basically counting what you do, getting paid for what you do, and there's only certain ramifications. And I remember not just 5 years ago, if we stepped out of the intensive care unit and went down the hall to have a conversation with our patient, then that was not billable because we were outside the presence of the patient. We couldn't bill for a service that was provided to the decision maker, who was the durable power of attorney for healthcare, down the hall in the family room, because that was the right place to have the conversation instead of standing in the intensive care unit on a ventilated patient who was completely obtunded and unable to have a conversation with us. And we were taking care of our patients and their family by having this conversation down the hall. That became billable when we were able to bill for prolonged services outside the presence of the patient, in recognition of the fact that our palliative care visits did typically take longer than the threshold time that was included in the initial evaluation and management code. So great, but even the best performing palliative care teams only cover approximately 50% of their billing. And in a fee-for-service model, only the physician or the provider component of that billing is actually reimbursed. Social worker, nurse, chaplain, and sometimes pharmacists, often pharmacists, are not a reimbursable effort, but they're invaluable to the team. And we'll talk about that a little bit more. Remember that the highest quality of care, and the reason that we do palliative care, is for the patient and their family, if we think of them as the patient unit. And then we're at this quandary between increasing quantity, which will then decrease quality. It doesn't have to happen, but that's the quandary. And remember that the financial benefit that is incurred or that is realized with the provision of palliative care is primarily going to the payer. A little of it then also goes to the hospital and the system, but none of it comes back to the provider or any of the other caregivers. So we want to make sure that we know when and why to provide palliative care. There's a whole bunch of lists. I want you to memorize this because there's going to be a test on this in a little bit. Every bullet point, preferably in order, and I don't want you to do that because this is a long list and you cannot remember each of these. And imagine if you look at that oncology criteria and went to your med-onc team and said, you must consult us for this, that, the other thing. You're going to get blank stares and I don't want you to take away my clinical decision making and I've got this. But there has to be a communication and there has to be an understanding. And I kind of distill this down as I don't want you to go to an oncology team and say, you got to do this because ASCO says. I don't want you to go to your hospitalist and do the same thing. So I distilled this down and it actually comes down to really 4 things. Relationships are key in that communication pathway. Having an established criteria and an established process with your oncologist, with your heart failure docs, with your intensivist, with your hospitalist, et cetera, is key. But you want to have the conversation about what are the distressing symptoms that we can help you with. Your patients have unclear goals. They are going to have unanswered questions. And what we want to help you do is address this unmet need. If you take this set, and this is not all inclusive, it does not get into the nitty-gritty details, yes, but these 4 clear, precise, concise criteria will help you have that conversation when you're forming that collaboration and when you're forming that decision-making matrix. Now, hopefully, all of you can check off every one of these because where do we provide palliative care? You're all in tertiary medical centers, emergency departments, SNFs, assisted living, et cetera. And remember that most palliative care was either started in the hospital or out of hospice, and never the twain shall meet. And the ideal palliative care team is going to be integrated, communicating, and seamless. And we're struggling with that. And we are a 51 hospital, now 53 hospital system. We struggle with it as well. And just like every system and every hospital across the country, our palliative care teams were stood up, taking available resources, matching it to identified need, and building it de novo. We are in the process, and just like everybody else, setting that level playing field so that we reduce that clinical variation. And so we do have best known practices across the system. And when you walk into this hospital in Southern California or this hospital in Eastern Washington, that you're getting the high quality care that we all know and love as palliative care. I tie this all together because with COVID, and one of the things that we realized is that digital platform over there on the left became the connection between all of these settings. And so if we can connect all of these dots, especially to the rural, the primary care clinics, the specialty clinics, home visits, et cetera, then we can actually check off the access and availability that we struggle with. Now, I don't know if you guys know this, but there are just over 6,000 hospitals in the United States. More than 5,000 of those are actually community hospitals. 1/3 of the community hospitals are in rural settings. So 1/3 of our hospitals in the country are outside of even having access to these tertiary medical centers, except by transfer and except by a lengthy either helicopter or ambulance ride. So how do we reach these folks? And they're important because these are critically ill and seriously ill patients out in our communities. But remember that there are more patients outside of the hospital than inside of the hospital in need of palliative care. We've talked for years about post-acute care and advanced illness management as the buzzwords for palliative care. And those look at, once a patient is discharged from the acute care setting, how do we prevent them from coming back? As we move into this value-based purchasing and as we recognize and realize that the best care actually is ensuring that the patients don't ever come into an unnecessary hospitalization. They don't come into an acute care tertiary medical center when they don't need to. We either keep them in their rural hospital if that's appropriate, their critical access hospital, keep them in their homes or in their living center, wherever that is, avoiding that critical access transfer to a tertiary medical center, because I don't know about your hospitals, but there are a bunch of sick people and a bunch of bad things that occur inside of the hospital. And so our models have been built differently across the country, and we have a variation from a full consultation team, which is going to be like you would for any of the other specialties. So you get recommendations, you get guidance, and it's a very quick handoff all the way to the other end of the spectrum, which is a full inpatient palliative care unit where the palliative care provider assumes the primary attending status, manages the entirety of the care, and there is eventually no handoff until discharge. Most of our programs and most of the programs across the country based on the literature show this middle of the road co-management, which involves the recommendations that we talk about in consult, but also has a collaborative approach to recommendations and maybe writing prescriptions and maybe writing pain management and symptom management. And then handoff occurs when it's needed. As you can see, in a consultation only model, the number of consults is going to vary greatly and is going to be increased, whereas in a daily management, you're going to be able to see fewer. And this is per provider. This isn't per hospital. You could have a large number of consults with a large number of providers, but that's what I'm talking about right here is per person. You can only do so many things in one day. So which one's best? And it's going to depend on your location. It's going to depend on your individual hospital. It's going to depend on your leadership's decisions on what they want to do. But the foundation of this entirety is the interdisciplinary team. And at the end of this slide deck, you'll see a whole bunch of resources. I'll point everybody to the National Consensus Project, the criteria and the best practices for the interdisciplinary team do call for a provider, a social worker, a chaplain, and a registered nurse, whether that's an advanced practice or registered nurse. And I also throw in pharmacist. I really like this visual surrounding the patient and the family as the identified patient and family, but I realize that we've been using this visual for a while. And the thing that I don't like about this is that there's too much white space and there's too much gap. And so I kind of tweaked it a little bit, especially when you take into consideration that the term palliate actually comes from the Greek to cover. I don't want to think of this as smothering because it does look like they're kind of cramped in there, but when you look at the Greek to cover, to swaddle or cover, which is what the palliation approach is, it's that extra layer of support. And so bringing everybody into taking care of the patient and family. But you can see, I like the visual here because there is a ton of overlap. And remember that identifying and clearly having your team built out in support of each other with that overlap is what's going to allow everybody to serve at the top of license. So what does an interdisciplinary team mean? We talk about IDT. I like the idea of moving into a transdisciplinary team. I don't know that anybody has really achieved that. So we're going to talk about IDT, this interdisciplinary team, and look at what it means. And so each of the caregivers has a specific role. There is overlap on what they do, and you really want each of your caregivers to be providing their specialty skill set. Your social worker is not going to be prescribing opioids or opioid equivalents. Your chaplain is not going to be doing social work for the most part. Now, my favorite, you guys saw this at the beginning, I have an MD and an MSW. I was a social worker first, and palliative care physicians are hands down the most social worky group of physicians I have ever worked with. But you don't want your physician providing social work. A, it's expensive, and B, it's not the best care. As social worky as palliative care physicians are, they are not trained clinical therapists that are social workers. And palliative care social workers are not medical social workers. Palliative care social workers, like hospice social workers, are therapists. And that is a distinction that is very important on building your team. Over here on the side, I'm going to show you an example of what it looks like to have an interdisciplinary team for 1,000 annual admissions. Now, this is an average 125 bed hospital. And you're thinking, wow, our hospitals are much smaller than that, or our hospitals are much larger than that. And I picked an average as an example, and then this could be extrapolated to larger or to smaller. Now, I will call out that it is very hard to build an interdisciplinary team for a hospital volume lower than 3,000 annual admissions, and we can talk about that individually. I welcome questions about that. I love designing teams and proposing growth strategies for these because it impacts the care that can be provided in all of our hospitals. But for this example, it's a 125 bed, let's say, rural community hospital with 1,000 annual or 10,000 annual admissions. They're doing really well. They're at 8.5%. We just jumped back to the beginning. Okay, thank you. They're doing really well. They're seeing about 8.5% penetration, 7.5% penetration. Is that me? I'm not sure.
It is not you, Kevin. You can keep going, and
okay.
we'll fix it. Yeah.
Okay, thank you. So they're doing pretty well. They have about 7.5%, pushing 8% penetration, which is well above the national average. And if you take an average of the provider sees approximately 2 follow-ups, 2.5 follow-ups per, the social worker is seeing even more. And this just counts an average number of touches. Touches would be visits throughout the course of that tenure. And this is assuming that middle of the road co-management consultation team. And what you can see is that the number of touches is not insignificant. There are a lot of people involved. The distribution over here on the side is showing that everybody has a very large contribution to this mix. Let's see if we can go to the next one. Yeah, there we go. But what happens if we get rid of the social worker? I hear a lot of teams say, yeah, my ministry, my boss, my hospital, my CFO says that we can't afford to hire a social worker, so we're going to just do the interdisciplinary team with a doctor, a nurse practitioner, a nurse, and this is unusual. You know, we have a chaplain and a pharmacist, but no social worker. But I wanted to just remove one player as this example. You can see that the number of consults goes down. The number of provider touches goes up. That number's wrong, I'm sorry. It's not the point. The point is that you see there's a new category over here on the left that is cutting into those provider visits. That's now, and thank you to my daughter Kate, who taught me this word, this fuchsia here on the left is unbilled provider visits, because your provider is giving social work support. When your provider gives social work support, it takes away from their top of license time, which would be billable time. As you increase the touches that everybody else is giving and you decrease your billable time, you're going to save about $80,000 salary and benefits on that social worker, but you're going to lose about $104,000 in revenue. So your net loss is $25,000-ish for taking the social worker away from your team. You're decreasing your capacity, which we'll talk about more, because reduction of 150 consults is actually going to be closer to $350,000 lost when we get into this direct cost savings that we'll talk about here in a little bit. And I presume that we're going to have a ton of questions about this, and we have some time carved into the end for that specifically. So billing practices. I hear a lot of programs say, I'm not really comfortable with billing, so I just bill everything at a level 2. And so I built that in. What does that look like for the same number, 750 consults, same size team? You're going to pull in a whopping $242,000. Okay, I can't tell the difference between whether it's complexity or time, so I bill everything on time. You're going to bring that up just slightly to 300,000. Well, not okay, great. Now we're going to jump over to the extreme. Well, this is palliative care, so it takes longer, and we do advanced care planning. And I'm going to add an advanced care planning code and a prolonged service code with the patient and a prolonged service code without the patient to every one of my E&Ms, and then I can just ramp that up, and I'm just raking in the bucks. And then I tied in the, okay, that's not true. You're not going to have an advanced care planning code or a prolonged service on every one. A realistic expectation is that a certain portion of them will, a certain percentage of them will. If you bill correctly on your evaluation and management and correctly on your prolonged services, advanced care planning, you could see this revenue. So $518,000. This is Medicare allowable net. So the thing that I want you to take away from the slide is if you look at time only versus realistic, you're leaving about 35+% on the table if you bill only on time. Now, the other thing about this is that E&M plus prolonged services plus ACP is actually illegal, and then you'll be billing zero because your physician is going to be excluded from CMS. So I highly recommend that you don't do that. Okay, and you say, yeah, but I have expenses. I have to pay my physician. Yes, you're right. And so this blue category is the initial and subsequents lumped together. The orange is your compensation. That's your full team, your full interdisciplinary team. And so your net is this fuchsia again, where if you underbill or you bill on time only, you're going to have a deficit of 350 or 400,000. If you illegally bill, you're going to be positive, but again, I highly recommend that you don't do that. Realistically, a realistic program for this is going to still function as a deficit, and this is a min-specs team, so this is a low salary cost. You're going to be running in the red about $126,000. But most importantly on this slide, what I want you to see is that realistic one is the one that I want you to show about, because just like overbilling, underbilling is considered fraudulent by CMS. You won't get in quite the same trouble, but it is still fraudulent billing. So don't underbill, don't overbill. All right, so you mentioned this direct cost savings thing, and how do I calculate that? And CAPC has been beautifully enumerating that value for us for years. I would say my good friend Sean Morrison, but ever since I made a bad joke at one of our CAPC conferences when he was tooling around on a scooter, I don't know that he considers me his friend anymore. But he has been showing us the value of inpatient consultative palliative care for years. It used to be a split number between discharges and deaths. Now it is just an average number. The number that CAPC uses for palliative care intervention is 3,274. If you use the CAPC calculator, it's built into that. But what we did is we looked across our 52 hospitals, all of our palliative care interventions, all of our palliative care services. We compared those to non-palliative care pre, post, and early. And we learned that the biggest impact that we see within our system is when that palliative care intervention occurs in the first day of admission, by definition, before the second midnight. And there is a 9-fold increase in direct cost savings when palliative care occurs earlier. So that just screams to the importance of having a partnership, identified indicators as to when to consult palliative care, and executive directors and chief executives who are encouraging and directing hospitalists and intensivist teams to utilize this valuable resource. So great. My palliative care team can't see early patients. We see them at 3, 4, 5, 8 days. That's okay. What I want you to see from that is even with late consults only, you're still bringing a positive value proposition, that's the purple, to the team using those same criterion before, where the number of patients, the number of team members, et cetera, is the same. We currently, in 2019, and across Providence, are at about 33% of all of our consults occur in the first day of admission. So we are, ironically, and this was not on purpose, we are actually lockstep with CAPC's average. So if you compare our current state, 33% across 53 hospitals, with CAPC's recommendation, we are within seconds, pennies, what number you want of that. Now we have set for us a goal of pushing that to a higher penetration with a greater number of early, and not because of the dollar amounts, but because of the trajectory of care being impacted the earlier that you get involved. Oh, and then I guess I'll point out that the net value here, 750 consults, 4 FTE team realizing a 3.25 net value via palliative care interventions. Okay, so we set out and developed a platform, a 4-pronged platform of access, culture, quality, and future, because we have to have the resources to do this. Across Providence, we wanted the care to be the same or equivalent no matter where you were receiving it in the country. So we have set lofty goals of 10% and full IDTs. The full IDT for the hospitals greater than 10,000. And to do that, we've set some system level metrics that are actually probably some that you guys have heard of. PC penetration, this early PC metric, and we have added 7-day-a-week coverage. One of the things that we struggle with is the fact that my patient on Sunday is less sick or less in need of palliative care than my patient on Tuesday. One of my ICU docs famously told me, if I don't need you on Sunday, I don't need you on Tuesday. And so adding that 7-day-a-week coverage, being available in person in the hospital for more than 40% of the time that is involved in a week is imperative. The last one we tied into this metric that's a system-wide metric is this unmet need, which is actually measurement of the Dartmouth Index serious illness. And so we took a look at all of the seriously ill patients admitted to our acute care facilities, and then as the numerator, those who had 4 or more of those comorbidities. Now those are serious illness Dartmouth Atlas, so CHF, COPD, cancer, et cetera, and that list is at the end of this, so I won't list them all out for savings of time. But we as a system still have a significant number of patients with 4 or more comorbidities in our hospitals not seen by palliative care, and we define that as unmet need. I like this, I'm not going to belabor it, but it's a process. Remember that as we define those pillars, and it's about having the caregivers and having the resources and having the structure and having the culture, what we learned is that you can not make system level change without having the palliative care team available, but also the resources at the top saying, yes, this is important, this is a priority. And so I've included this for you folks to take a look at, but the things that have made the biggest impact for us across all 50 plus of our hospitals is ensuring that the resources are available for the patients. So what is the palliative care resource? That is the team. You have the full interdisciplinary team available when and where the patients need it. And so to track this, we developed a snapshot dashboard, which this is blurry on purpose, don't worry. One of our higher performing hospitals, and we look at operational key metrics at the top and all of those graphic depictions of the quality and quantity metrics at the bottom. But what we distilled it down to was service line partnerships and integrations, coverage, so your 7-day-a-week availability, workforce, meaning you have the resources and the interdisciplinary team, and then a form or an agreed upon proactive identification to early PC. The quote unquote triggers or proactive indicators are rarely well received by your partner team. So your oncologists, your intensivists, your hospitalists don't really like their quote clinical decision making taken away from them, but an agreed upon proactive identification system is going to be imperative to move that bar to the earlier. Now, one of the things that we have been surmising is that being there in person makes a difference. And so here's a side-by-side comparison of what happens when you have 7-day-a-week coverage. None, if you're available on the weekend by phone, or if you're available in the hospital 7 days a week to be personally there and physically there to do a consult. You can see that the jump from 5.75 to almost 8 in penetration is significant, and there's only a small increase in the early from the by phone and in person, but that is a much larger number of patients being seen early. So the fact that you're seeing fewer patients early, the takeaway from this is that you have 6 patients in your hospital on the weekend, you have 6 patients in the hospital overnight, and the sooner you can get to them, the greater the impact you're going to have on their trajectory of care. So the struggle that all of our programs have is when I'm starting out, I want to make sure that I give the highest quality care, that I am impacting pain and symptoms, that I am impacting the bottom line dollar, that I am impacting patient satisfaction, that I am impacting caregiver satisfaction. And that is a laundry list of quality and quantitative measures that you will not be able to implement at the outset. We highly recommend that you start with process metrics and maybe one outcome metric. When you launch a program or early on in your program, having access and availability. So do I have a palliative care team? Do I have access 7 days a week? Those are high quality process metrics. You want to define your population. Who am I serving and what is the impact that I want to set from them? And from that, you can develop a quality metric. I'll give my third shameless plug, my friend Steve Pandelat and the palliative care quality PCQC now coming out of PCQN is launching last month. Very, very robust list of quality and performance metrics coming out of there. We are working with them. We have not signed on the bottom line, but we really enjoy working with them. Great team, great resources, and we're moving in that direction. So highly recommend looking at that for no other reason than it takes the data collection out of your provider's hands. And if you're paying your docs to do data collection, that's also very, very expensive data collection. And so this is a comprehensive list of the metrics that we have been talking about. And I realize that this has been at about 100 miles an hour because I wanted to get these information in front of you and give us a little bit of time to talk about what's going on and some of the things that you guys can do, meet boots on the ground and pens on paper there in your individual locations and hospitals. And let's transition to that. But you can see some examples of team optimization and collaboration metrics that we have been using. There's unmet need within the hospitals. I usually say, this is the example of, I am asking you to go fish and that pond has fish. It is not an empty, unstocked pond. There are needs in your hospital, there are needs in your ministry, and they are going to be lagging indicators, but they are going to be very definitive and very specific indicators of the quality and the availability of your palliative care teams. And I'm going to transition this back to Denise, and then we're going to go through some questions.
Great. Thank you so much, Kevin. As usual, you have packed in so much great information in a short amount of time. And I just want to thank you up front and call our audience's attention to the fact that you have generously provided your contact information, because I have no doubt that we are not going to get to all of the participant questions today. But having said that, those of you who haven't already done so, you'll notice on your webinar platform dashboard that there is a chat box feature, and you can add your questions in there. Another thing to note is, if we don't get to your question today, those questions get forwarded on to Kevin too. And so when we have you back another time, you'll have your agenda all set out for you. But without further delay, there are several questions that all circle around this same theme. There is this ideal palliative care team, alignment with the National Consensus Project guidelines. Then there's the real palliative care team based on how much money, how much FTE, if it's a hospital system is willing to fund. Given that you let us know that you love to build programs and get them going, what's your recommendations for, let's say, a system or a hospital setting that has 1.5 FTE? Some of the questions folks are asking are, well, we should absolutely spend that money on a physician champion who's going to, make the case to leadership. Others are saying, no, from the get-go, if we want to send the right message, it should really be some kind of interdisciplinary, interprofessional. So talk to that for us.
Well, I hate this answer, Denise, but it depends. So if you have 1.5 FTE, it's going to be creative. So you're going to need to look at your hospital. So for us, Catholic Healthcare, we have a chaplain in every hospital. If I was given 1.5 FTE, I would not build a chaplain into that budget, but I would purposely go to my spiritual care leadership and say, all right, I need an active relationship, and I need to know how often can I call on you, and how can I ensure that my patients' end of life or critical illness, spiritual care needs, existential crises are going to be addressed by the right people. And having that in place, then I could move forward with, okay, what do I do with the rest of it? My recommendation when I'm building a team is an equal part provider, non-provider. Provider is anybody billing. So physician, nurse practitioner, PA, what have you. Your regional or state mandates are going to indicate whether or not your nurse practitioner can function independently or not, your PA can function independently or not, and you're going to have to follow those. But if you have an equal component, so 1.5, so 0.8, 0.8, 0.75, 0.75, provider, non-provider, whether that's nurse practitioner or physician is going to depend on your hospital culture. If I were doing it, I would make sure that there was a supervising physician for whatever limited amount I could, and then have the nurse practitioner be the meat and potatoes of that provider component paired with a chaplain. And that 0.75 nurse practitioner impacting, let's say, 275, 300 consults per year is going to show exactly what the potential is. But the thing that I really want to call out is if somebody gives you 1.5, you take it. You don't say, I can't do it. You take it, you build it, and you have in that conversation, all right, this is not going to be enough, and I know that, and let's make sure that we're all on the same page. I'm going to show you in the next year that there are still patients who need palliative care. I'm going to show you that those patients who receive palliative care get the best care possible, and these are the metrics. Let's say length of stay, readmission, and discharges to hospice, for example, are the criteria that we're going to show. We're going to show you that they get the best care, they have shorter lengths of stay, they cost you less, and that's why you're going to want to add another full FTE next year. And have that conversation early on. Remind them as you go along, hey, remember we had this conversation, this is what we're seeing, this is what we're doing, and I want to get that ball rolling now. Excellent.
Thank you for that it depends answer, because yeah, that is right. There can't be one answer. You are so right. So next question, folks are saying, okay, so I'm using these tools. I've listened to both of your webinars. I'm no longer leaving money on the table, especially with all of these new guidelines and rules coming out from CMS. Should I, budgeting time is coming around, should I adjust my palliative care budget accordingly based on what's happening right now in the billing and reimbursement world?
We're seeing a lot of CFOs and financial leaders saying that palliative care as a, quote, nice to have is one of those areas that we're going to potentially not grow or cut. I think that is the wrong approach. COVID-19, among everything else that's going on, is creating a scenario of sicker patients, not less sick. The needs are increasing. The value of that care is increasing. And so it's kind of like shutting the door during an evacuation. You want to keep it wide open. You want to have the resources there. You cannot have those realized savings, that financial impact that we talked about in direct cost savings, without those resources. I hear one CFO that I work with on a regular basis, we will just be more efficient. I know you say that one doc can see this number of patients, but we're going to be better than that, and we're going to double it. So my doc's going to be twice as efficient. And I say, you're right, your doc could be twice as efficient for a few months. Then you're going to burn them out, and then you're going to not have a doc, and then you're not going to have a program, and then your 1.5 million, 2.5 million, whatever direct cost savings is going to plummet to zero. And then it will take you another year to 2 years to recruit and refill that position. So I don't want you to be held hostage by the physician, because there are other docs if it's the wrong doc, but you don't want to lose a high quality physician or high quality caregiver just because you're trying to be frugal or you're trying to make ends meet.
Absolutely. Absolutely. Well, this will be our last question, a full minute to answer, but this one always gets asked when anyone from Providence provides one of our webinars. And I've given you a whole, well, it's probably less than 60 seconds now to answer it. And again, I'll remind folks who we did not get to your questions, please reach out to Kevin. His email's there on the screen. So clearly you all have had success in making the case to highest levels of leadership within Providence. What's your secret sauce?
Persistence. It's really what it comes down to, is don't take no for an answer. Make sure that you have all your ducks in a row and say it often. So we're coming into an election. I will not follow suit with the vote early and vote often mantra of Hubert H. Humphrey and Daley out of Chicago and our current executive administrator, because you should not vote twice, no matter what is said, but you should have this conversation multiple times, because even the most stoic of CFOs can come around. Remember to always have stories with your data and never have data without a story.
Excellent. Thank you. Wow. And definitely in 30 seconds or less, you did that. Thank you so much. And thank you again, Kevin. We so enjoy,
Thank you. My
appreciate
pleasure.
every time you share your expertise and perspective with us. Again, thank you to all those who joined us in the midst of all that is going on in your personal and professional lives right now. We appreciate your taking the time to join us. There will be a survey that will pop up on your screen as you exit the webinar. We invite you to just take a couple seconds to complete it. We use that information to plan future webinars. And save the date, October 15th at 1 o'clock Eastern Time. We are glad to welcome Reverend Dr. Gloria White Hammond. And if you haven't heard her before at AAHPM and various conferences, you will not want to miss her. The title of her webinar will be God is Able, the Significance of a Belief in Miracles for African American Patients with Serious Illness. Registration for that webinar will be opening up soon. Those of you on our mailing list, you'll be contacted as soon as registration is open. This webinar was recorded and you will receive an email tomorrow with access to listen on demand. Thank you, everyone. Stay safe and stay well.